Thank you, Professor Mohan sir, and thank you for having me here. Good morning, everyone. It's wonderful to see this packed house. For many standing behind, there are chairs available ahead, and you can ask the people taking 2 seats to spare one for you, so you can come ahead.
And there's also an overflow hall. If you want to sit more comfortably, the overflow hall is also there. But there are few seats in front. Please do come.
Right, so we heard this wonderful conversation from Dr. Banshi about the new basal insulin. Well, let me take it a step ahead and talk about another wonderful option that we have, which is iGlarLixi. I am contracted for this talk by Sanofi. Dr. Mohan started this symposium telling us about the statistics through the landmark trial. The underlying pathophysiology of diabetes continues to be complex. 63% of type 2 patients remain uncontrolled. 66% participants were obese in the landmark trial, and 21% patients already have micro and macrovascular complications. So clearly telling us that inertia doesn't do any of us any good. So there are unmet needs in advancing diabetes management. Options for advancing basal insulin therapy in adults with insufficiently controlled type 2 diabetes. So let's say we've taken that first step of insulinizing our patients, but for those who remain uncontrolled, what are our options? So beyond basal insulin, the option is you go basal plus, which is add 1 prandial insulin, or you go into multiple boluses, you switch over to pre-mixed insulins or co-formulations in our country. You also have the option of using basal insulin separately along with any of the GLP-1 receptor analogs available, or you today have the option of using one device which has basal insulin and GLP-1 as one single device. So there are potential advantages and challenges associated with all of these various treatment options. A busy slide, but when you talk about progressive addition of rapid-acting insulin, so you're talking about basal plus or basal bolus, there are some advantages that you start with a single prandial dose, you can titrate, greater flexibility for people who don't have a tight schedule. But there are more hypoglycemic risk when you use prandial insulins. Also, very often basal plus doesn't suffice and you have to keep stepping up the number of injections, and of course the worry of weight gain with excess insulin. What about switching over to premix insulin, which has been a favorite choice in India? Well, it's a simplified regimen, yes, as compared to 3 or 4 shots a day. 2 shots of premix has been preferred, but the titration may be again difficult, and again, unfortunately, higher chances of hypoglycemia and weight gain there. What about addition of once daily or once weekly GLP-1 receptor analogs? So it has shown similar efficacy to the various options. There is lower risk of weight gain when you're using a GLP-1 receptor analog. Weight loss is there. There is organ protection through the GLP pathway, so it's a great option. However, when you use these more potent GLP-1s, which come more or less in a fixed dose, there are higher chances of gastrointestinal adverse events. Additional injections, of course, required, and sometimes there is confusion in the minds of the patient about which one how to titrate and how to go about it. And then, of course, you have the fixed ratio combination of basal insulin and GLP-1 has shown potent glucose lowering actions, which I will show the evidence for. It leads to reduced total insulin dose, lesser weight gain, lesser hypoglycemia, once daily administration, and of course, reduced treatment burden on the patient. And I think that should be one aspect which drives us when we treat our patients, which is patient adherence, patient comfort, leading to patient compliance. So I don't think our job as a clinician is over when we write those prescriptions, which may seem very, very idealistic, and before and after and bedtime and 20 minutes before meals and so on. We also need to decide that our patients have to do this day after day, year after year. So let's simplify and have empathy in our prescriptions as well. So what opportunities could a combination of this basal insulin and GLP-1 provide for our patients? Opportunity to address the multiple different physiological defects, increase convenience leading to better adherence and compliance, earlier achievement of the targets and greater persistence and durability, potential reduction in the risk of side effects, both by not using excess insulin and not using excess GLP-1, and potential to delay the underlying disease progress and reduce the chance of complications. So combination of basal insulin and GLP-1, to one side you have basal insulin, and we saw some wonderful data. It targets your hepatic glucose overproduction, decreases your gluconeogenesis. Your basal insulin largely will target your fasting sugar. and it tries and gets your fasting sugars to target. On the other side, your GLP-1 component will have a more glucose-dependent insulin release, reduces the glucagon secretion, to some extent would delay the gastric emptying, and reduces your postprandial spikes today, which we monitor so well through continuous use of CGMs. So iGlarLixi targets 7 out of the 8 pathophysiological abnormalities of type 2 diabetes. On one aspect, we mentioned about reducing hepatic glucose production and gluconeogenesis, increase uptake of glucose in the muscles, and reduction in lipolysis. On the other side, your GLP-1 comes in, as mentioned, increases only your glucose-dependent insulin release, reduces the hyperglucagonemia, which often we ignore in our patients with type 2 diabetes. The hyperglucagonemia or overactive alpha cells contribute so much to our patients with type 2 diabetes, improves satiety and reduces gastric emptying. So the global guidelines also today are very clear on the combination injectables. The ADA speaks about combination of basal insulin and GLP-1. The ACE and ACE in 2023 itself spoke about the failure of OADs or GLP-1. Look at this combination of basal insulin and GLP-1s. And the ADA-AST since 2022 has been talking about the combination of use of basal insulin with GLP-1s. So let's look at the clinical evidence. It has a huge wall of evidence in adults with type 2 diabetes, multiple different studies. You had studies in patients who've been suboptimally controlled on OADs, the Lixi-Lano and Solid-D. Those who were suboptimally controlled only on basal insulin, Lixilan-L and Solimix. Suboptimally controlled on GLP-1s, Lixilan-G, Lixilan-G extension, and switching from premix insulin. So we'll cover 2 of these studies today. Let me start with the Solid-D study, an important study, which was iGlarLixi in type 2 diabetes patients suboptimally controlled on oral antidiabetic drugs, where you're actually comparing 2 of the options. On one side, you have iGlarLixi, and on the other side, you have IDEG-ASP. A prototype for such a patient could be a 45-year-old diabetic for last 7 to 8 years on metformin with any of the other OHAs, A1C around 8.5, BMI 25. And when you think back, you will see, I have a lot of patients which are similar to this profile. So let's see what the study had. The population was adult diabetics with more than 3 months on a stable dose of metformin with any other second oral antidiabetic drug, BMI less than 40, A1C 7.5 to less than 11 if they were on SGLT2, or 7 to 10 if they were on any of the other oral drugs. After screening, they are randomized as one arm to iGlarLixi once daily, and the other arm was IDEG-ASP once daily. Their metformin and the baseline drugs were continued. The primary endpoint was non-inferiority in HbA1c change from baseline to week 24. You look at the baseline characteristics in both the arms, iGlarLixi and IDEG-ASP, when you see almost similar baseline characteristics well distributed, be it age, female ratio, BMI, and so on. So what did the Solid-D study show? It showed superior reduction in A1C from baseline to week 24 with iGlarLixi. So you're getting a 1.88 reduction in A1C as compared to 1.68 in the IDEG-ASP arm. You also saw benefits on the weight and total required dose being lower for iGlarLixi as compared to IDEG-ASP. So you can see some weight reduction in the iGlarLixi arm as 1.2 kg increase in the IDEG-ASP arm, and the total dose required was 28.2 in iGlarLixi as compared to 34.1 in the IDEG-ASP arm, which is a significant difference. Also, when you look at the different composite endpoints, whether it is patients reaching A1C less than 7 at week 24, or those reaching less than 7 without body weight gain, or without body weight gain and no hypoglycemia, in all these 3 secondary endpoints, you will see iGlarLixi in the purple outscoring IDEG-ASP in the bluish shade. So in all the 3 aspects of 3 different composite endpoints, iGlarLixi did better than IDEG-ASP. Also, there was lower incidence and event rate of hypoglycemia, including nocturnal hypoglycemia as well. So you look at anytime hypoglycemia, iGlarLixi lesser than IDEG-ASP. You look at the 2 different levels of hypoglycemia as defined by ADA, level 1, which is 54 to 70, or level 2, which is less than 54, iGlarLixi doing much better than IDEG-ASP there. So the Solid-D study, we could conclude that it has statistical superiority in A1C reduction to IDEG-ASP, superior body weight benefit for iGlarLixi, more patients achieve the composite endpoints, lower risk of hypoglycemia, and no unexpected safety findings. We then moved to look at the SOLIMIC study, that iGlarLixi in type 2 patients who are suboptimally controlled on insulin. So from basal insulin, when you are switching over, do I switch over to twice daily premix, or do I move to once daily iGlarLixi? Again, you have a prototype patient, 57-year-old, diabetes for last 12 years, on metformin, SGLT2 with other OADs and basal insulin, A1C around 8.7. So your current strategy is not good enough. You need to move ahead. What are the options? Let's learn from the SOLIMIC study. Population diabetics for more than 1 year, more than 18 years of age on basal insulin along with OADs, A1C 7.5 to 10, BMI between 20 to 40, and the basal insulin dose at screening needed to be somewhere between 20 and 50. So that was your criteria. After screening, the patients are randomized to either iGlarLixi once daily or BIASP twice daily. Total of 887 participants were included from 89 countries across 89 centers across 17 countries, and India contributed about 182 patients to this study, so well represented from India. What did we see? So iGlarLixi again showed superior A1C reduction and weight benefit versus bias given twice daily. So you look at the iGlarLixi arm and the reduction in A1C is 1.3% using it once daily, whereas for bias used twice daily you had an A1C reduction of 1.1%. It was also superior in body weight from baseline to week 26. Again, in the iGlarLixi arm, you're seeing a 0.7 kg weight reduction, whereas in the bias insulin twice daily, you're seeing a 1.2 kg weight reduction. Now, these kind of findings make your choice as a clinician easier, that when I want to move beyond basal insulin, what do I really choose? Is it the traditional premixes that we've had, or a combination of basal and GLP-1 which is available for us to use? You look at the composite target achievement, just like I showed for the SOLI-D study. You're looking at patients getting an A1C less than 7, those at less than 7 without weight gain, and the third composite of less than 7, no weight gain, and no hypoglycemia. Again, in all the three sections, your iGlarLixi did much better than twice daily bias 30. You also look at the total insulin dose. Again, you see in terms of from basal insulin, the incremental dose when you move to this, you see a plus 10.6 in the iGlarLixi arm as compared to 22.9 units higher overall insulin dose for the bias arm. Lower risk of hypoglycemia at any time of the day with iGlarLixi versus bias 30 in the SOLIMIC study. So when we conclude and summarize the SOLIMIC study, iGlarLixi versus bias 30, better glycemic control with weight benefit seen here, less hypoglycemia, of course fewer daily injections, similar proportion of adverse events in both the treatment groups, which concluded that iGlarLixi for us is an efficacious, simpler and well-tolerated alternative to premix bias 30 in uncontrolled patients with type 2 diabetes. Finally, let's understand how to use this drug properly and its use in special populations. So iGlarLixi, you have a ratio, it's available in 2 units of basal insulin to 1 microgram of lixisenatide, which is a short-acting GLP-1. So in your 3 ml pre-filled pen, you get 300 units of glargine and 150 microgram of lixisenatide. The dose ranges from 10 to 40. So you start with 10 and go to 40. How do you start? For your patients who are insulin naive or those who are on basal insulin less than 20 units, you will start with 10 dose steps of iGlarLixi. For those of your patients who are taking more than 20 units of basal insulin, 24, 28, you will start with 20 dose steps of iGlarLixi. So simple to remember, for those who are injection or insulin naive, you start with 10 units. Those who are on basal insulin more than 20 units, right, or any insulin more than 20 units, you will start with 20 dose steps of iGlarLixi. And you can see that with each dose step, what is the amount of lixisenatide and insulin available. The dose titration can be simple. You are looking at a fasting target of 80 to 100. Where the sugars do remain above that target, you could do +2 every week, and if the sugars are dropping less than 80, you could do -20. This is something that we learned largely during our start of glargine, and this kind of learning continues here also. Timing, it should be injected subcutaneously once a day within 1 hour prior to a meal. So whether it's breakfast, lunch, whichever meal you choose, 30 minutes to 1 hour before is the instruction that I give. It's preferable that the injection is performed for the same meal every day, so that needs to be maintained. And in case you asked your patients to take it at breakfast and they forgot at breakfast, they can take it before lunch that day, 30 minutes to 1 hour before. What about use in special population? So elderly, well, it's found to be safe and can be used in elderly patients. No dose adjustment required. It's going to be similar starting dose and titration. For those with renal impairment, with mild to moderate, safe to use. When the GFR falls less than 30, it's not advised to use these. For hepatically impaired patients, it can be used in them. For lixisenatide, again, no dose adjustment is required for patients with hepatic impairment. Pregnancy, it's not been tested and not advised to use iGlarLixi during pregnancy. So let me summarize this for us today. iGlarLixi is a synergistic combination that provides effective fasting and postprandial glycemic control. All the evidence that I showed and much more which I couldn't show has proven effective A1C reduction, good fasting as well as postprandial glycemic control. It does address the various different multiple pathophysiological defects in your patients with type 2 diabetes. More people are achieving targets with the use of iGlarLixi as compared to just traditional insulin or premix approach. Convenient once a day dosing. Weight benefits or neutrality seen, at least you're not gaining that much weight and having much lesser hypoglycemia, and improved GI tolerability in general as compared to the other GLP-1s that we've traditionally used. So iGlarLixi is the 10 to 40 pen that we have here. One injection once daily within 1 hour prior to the meal is the learning from this conversation. So combination injectable iGlarLixi. SOLID trial indicated that iGlarLixi is simple, well tolerated with better glycemic control, weight benefit and lower hypoglycemia rates as compared to iDAG-ASP. SOLI-mixed trial indicated that iGlarLixi is efficacious, simple, well tolerated alternative to the premix insulins that we've used, provides better glycemic control again with weight benefit and less hypoglycemia, and hence it provides us a viable option for our patients with type 2 diabetes. With that, let me thank you and thanks sir for having me here and invite you to DRS Cody in August in Mumbai, hoping to see many of you there as well. Thank you, sir.
Can we